and Services Administration, HRSA, Maternal Child Health Bureau, MCHB, EMS for Children, EMSC program, EIAC is supported in part by the HRSA, the U.S. Department of Health and Human Services, HHS grant number U07MC29829. This information or content and conclusions are those of the author and should not be construed as the official position or policy of, nor should any endorsement be inferred by HRSA, HHS, or the U.S. government. So our first speaker today is Dr. Manish Shah. He is the Associate Professor at Baylor College of Medicine, Department of Pediatrics. Our second speaker will be Dr. Kathleen Adelgais, Associate Professor of Pediatrics, University of Colorado School of Medicine, and practicing at Children's Hospital, Colorado. And our final speaker will be Dr. Katherine Remick. She is the Medical Director for San Marcos Hays County EMS System and the Associate Medical Director at the Austin Travis County EMS System. So that being said, I will go ahead and pass it over to Dr. Shah. Thank you very much.
Great. Thank you, Cassidy. Good afternoon, everyone. Next slide. I have no conflicts of interest to disclose. However, I just wanted to mention that the work that I will discuss during the webinar is related to several grants that have been funded by the Health Resources and Services Administration, as noted on this slide. Next slide. So imagine, if you will, that an ambulance is called for this child who's having a seizure. What we know about seizures in children in the pre-hospital setting is that it's a common condition that accounts for the majority of medically focused 911 calls for children. There's an evidence-based guideline for the management of seizures. There are quality metrics that have been proposed to improve care for seizures, and there's data that is collected every day for patients transported for seizures. Next slide. Yet despite all of these facts, the model thus far, with much of the important work that has been done to enhance EMS care, has been that guidelines are created and translated into protocols, quality metrics are measured, and data is collected in silos. And so what I would like to impress upon you today are how to not just enhance the evidence base for the EMS protocols that are used in your communities, but how to integrate protocol implementation and revision with data collection for relevant quality metrics in the care for children with seizures and asthma. And specifically, the objectives of my portion of the webinar are for you to determine how to modify EMS, asthma, and seizure protocols to be more evidence-based, and to identify several metrics to assess the quality of pediatric asthma and seizure care in EMS systems so that it is done in a unified manner to enhance quality of care. Next slide. So when we think about the reasons why an ambulance is called for a child, several conditions are very common. Trauma is by far the most common reason for an ambulance to be called for a child. But seizures and respiratory distress due to asthma are also common, and they're among the most common medical reasons why EMS is requested for a child. And because seizures and asthma are very common conditions that have an evidence base for care, at least in the hospital-based setting, they are ideal conditions for the development of an evidence-based guideline. Next slide. So the EMS for Children program was really at the forefront of the national initiative to create pre-hospital evidence-based guidelines. And in 2009, EMSC, in collaboration with the National Highway Traffic Safety Administration, funded the creation of the first 3 pre-hospital evidence-based guidelines to pilot the use of the National Pre-Hospital Evidence-Based Guideline Model Process. Hit advance, please. And so these 3 guidelines focused on pediatric seizures, the use of helicopter EMS, and pain management. Next slide. Another project that I led that was funded by the EMSC program through a Targeted Issues grant was the Pegasus project, also known as the Pediatric Evidence-Based Guidelines Assessment of EMS Utilization in States. Pegasus brought together a multidisciplinary group to develop 4 guidelines focused on airway management, allergic reactions, shock, and spinal care. And prior work from another Targeted Issues grant that I had focused on guideline development for asthma, bronchiolitis, and croup. And so as part of the Pegasus project, all 9 of these guidelines, the 3 developed from the first Targeted Issues grant, the 4 from the next one, and then existing evidence-based guidelines on seizures and pain that had been previously developed by EMSC, we implemented those in the Houston Fire Department in October 2014 and in several New England states in 2015. And so for the remainder of my portion of the presentation, I'll focus on two guidelines that we have studied thus far for asthma and seizures. Next slide. So in 2014, the Seizure Guideline was published in Prehospital Emergency Care along with the pain and the helicopter EMS guidelines. And shown here is a summary of the main recommendations that have subsequently been integrated into many protocols around the country. These recommendations have also been integrated into the National Association of State EMS Officials, or NASEMSO, Model Clinical EMS Guidelines. Though this evidence-based guideline was developed with the best available evidence at that time, knowledge translation in medicine, we know, is often delayed, especially in EMS. And next. And so I've highlighted here two main recommendations from the evidence-based guideline, and will provide examples about how we have done work locally in our system to improve adherence to these two recommendations, specifically the use of intramuscular or intranasal benzodiazepines as first-line treatment for seizures in the pre-hospital setting, and also to not place an IV or an intraosseous needle so that those intramuscular intranasal routes are used primarily. Next slide. And as part of the first EMSC Target Issues grant that I had, our guideline development committee for that project also created an evidence-based guideline for asthma, the main recommendations for which are shown here. We implemented this in 2012 in Houston, Dallas, and Austin. And as part of the Pegasus project, we enhanced the evidence-based guideline even further and implemented a revised guideline in Houston in 2014 and in New England in 2015. And so the major addition that we made to the guideline was in one area, and that in particular was the use of steroids, specifically the availability of oral steroids on the ambulance in the form of dexamethasone. Next slide. And so for both of the seizure and asthma guidelines, our team created potential quality metrics, which have also been integrated into the NASEMSO Model Clinical EMS Guidelines document. And those potential quality metrics are shown here. We studied a few of these as well, several for seizures and one in particular for asthma. And so our initial work focused more on process measures, but we hope to do a study in the future to focus more on outcomes measures. Next slide. For asthma, those metrics that we had proposed are shown here, and you'll see that steroid administration, which is on the second line, is one of the ones that is highlighted here. Next slide. So I will start first by discussing the work that we've done with seizures, since this is by far the most extensive. Hit advance. So despite integrating these recommendations into a protocol locally in Houston, there were still many opportunities for improvement in how we manage pediatric seizures in EMS. We had trained many of our EMS providers in the city through simulation training, and one of the emphases in the course that we conducted focused on seizure management. What we found, though, was that there wasn't a significant change with simulation training, in that many of the EMS providers at that time were still primarily using the intravenous route to manage seizures for the actively seizing child. Next slide. The study was eye-opening, however, because it showed us several interesting points about the management of seizures and what happens to children when they're seizing in the field. Several things that we noted were, one, that seizure activity upon emergency department arrival was fairly common, occurring in 1/3 of patients. Next, dosing errors occurred in half of the patients, 90% of whom were underdosed. Next. And there were delays in treatment, with the median time to benzodiazepine administration for the actively seizing child being 14 minutes after provider arrival on scene. Next slide. In a subsequent study in our system, we utilized a multimodal training approach that involved mandatory in-person training for all paramedics immediately preceding a protocol change, distribution of reference cards with appropriate drug dose and route guidance for seizures, and a social media campaign via Facebook and Twitter to reinforce main points for several months after the training. Next. From this study, we observed a significant increase in the use of the preferred intranasal and intramuscular routes from 29% from our data from several years prior to 74%. Next. But there were other outcomes that did not significantly change, including how often the patient received midazolam, which was about 2/3 of the time for the actively seizing child. Next. And I'll go back just a sec. There you go. And how often the correct dose of midazolam was given, and that was unchanged at about 57% of the time. Next. Integrating many of these recommendations from the evidence-based guideline into protocols in other cities, specifically in Charlotte and Milwaukee as well, through the CHAMP research node of the Pediatric Emergency Care Applied Research Network, we conducted a separate study to see if those changes that we made in protocols in other cities, if there were any improvements in some of these measures. And so across all sites, there was a 27% absolute increase in the use of the preferred intramuscular and intranasal routes after changing the protocol. Next. Also, there was a 10% absolute increase in the administration of midazolam to actively seizing children. Next. However, once again, we still notice that there is still room for improvement in the administration of the correct dose. Nearly half of the patients received the wrong dose of midazolam based on what the protocol at that time stated was the correct dose. Next. Specifically with regard to medication administration, there are many opportunities to optimize pediatric seizure management so that outcomes can improve. We compared the outcome of seizing on ED arrival in our before and after study in these 3 cities involving 533 patients, and we found some similar findings, similar to what we found just when we did a study in Houston, and that was that seizure activity upon ED arrival was still common, occurring in 1/3 of the patients. Next. That one of the reasons why patients are still seizing on ED arrival may be that many of them are being underdosed, and as noted before, dosing errors occur in half of the patients, and underdosing was still very common, occurring in 75% of those that received the wrong dose. Next. And another reason why seizures may not be stopping prior to ED arrival is that there are delays in midazolam administration, and we found once again that even in the other cities that it takes about 14 minutes for the midazolam to be given after paramedic arrival on scene. Next. And so seeing these potential opportunities for improvement in both process and outcomes measures prompted us to conduct a multi-center qualitative study to identify paramedic-reported enablers and barriers to adherence to the seizure protocol in Charlotte, Houston, and Milwaukee. Data from these interviews of paramedics who recently cared for an actively seizing child identified many systems issues affecting protocol adherence. 2 specific systems-level enablers were the availability of point-of-care references that obviated the need for dose calculation and the ability to provide medication by more than one route. Next. Several systems-level barriers included the lack of mucosal atomizer devices and intramuscular needles for infants, protocol ambiguity about whether or not focal and febrile seizures should be treated, and protocol ambiguity regarding maximum doses based on route. Next. Paramedics did offer some solutions to these barriers, which included simplifying dosing among all routes of midazolam, having point-of-care references matched to their protocols that decrease the cognitive load required to calculate medication doses in stressful situations, and addressing the barriers by clarifying the maximum pediatric dose, clarifying which seizures should be treated, and ensuring that the equipment is available for all sizes, for all ages. Next. So transitioning to the topic of asthma, for asthma management, we conducted a study locally in Houston to evaluate the effect of an evidence-based pediatric EMS asthma protocol update, inclusive of oral glucocorticoid administration on time to hospital discharge. This was a retrospective cohort study of children 2 to 18 years of age with an acute asthma exacerbation who were transported by the Houston Fire Department EMS system to 10 different emergency departments in the Houston area over the course of 2 years. We implemented the protocol update 1 year into the study period, requiring the glucocorticoid administration for all patients, with the major change being inclusion of oral dexamethasone at a dose of 0.6 milligrams per kilogram, maximum dose of 10 milligrams. So 482 asthmatic children were included in this study, and after the protocol change, we found that patients were more likely to receive a pre-hospital glucocorticoid. However, the administration rate only increased from 11% to 18% despite making the oral route available. Next slide. In this study, the median total hospital time after the protocol change decreased from 6.1 hours to 4.5 hours. This was a significant change. Total care time, defined as the time from ambulance arrival on scene to hospital discharge, also decreased from 6.6 hours to 5.2 hours, which was also a significant change. Overall, patients were less likely to be admitted to the hospital. That decreased from 30 to 21%. And those with more severe exacerbations were less likely to be admitted to a critical care unit, and that decreased from 82 to 44% after the change. Next slide. So to date, most national efforts to create evidence-based guidelines occur separately from initiatives to define quality metrics and work to define what data should be collected during an EMS patient encounter. We know that there are these NSEMSA model clinical EMS guidelines, that there's been prior work to define EMS quality metrics from the EMS Compass project. Hit next. That project has transitioned to now being done under the guise of the National EMS Quality Alliance, and that there are ongoing efforts to have a national database of EMS data that can be utilized to help improve quality. So next slide. However, it is essential to that a coordinated effort be considered when integrating evidence-based guidelines, tracking metrics, and collecting data on them. Next slide. And so what I hope I've demonstrated, at least using the examples of asthma and seizures in children, is how efforts in each of these areas should be interrelated to improve the quality of pediatric prehospital care on a national level, especially when it comes to seizure and asthma management. Thank you.
All right, thank you, Dr. Shah. And actually, as I switch over controls to Dr. Adelgais, I do want to go ahead and ask a question so we avoid some of that white noise that we might have. And it comes from Clayton Finken. And his question was there any control for the packaging of the midazolam? If in Ohio we often have at least 2 concentrates available to use at any given time, this sometimes contributes to missed dosages as a systems issue.
No. So in the prior studies that I've mentioned, either in Houston or in Charlotte, Houston, Milwaukee, the midazolam that was used was what was currently being used by the EMS system. Sometimes that was, in some systems, they used the 5 milligram per milliliter midazolam concentration, and another system uses the 1 milligram per milliliter midazolam concentration. So each system only carried one type of concentration, but there was never, despite the challenges of drug shortages, while we were doing those studies, there was never a time when the concentration that the EMS system carried was not available.
Thank you, Dr. Shah. Appreciate that. And that being said, I will pass it over to Dr. Adelgais with Children's Hospital of Colorado. Thank you.
Can everyone hear me okay?
We can.
Okay, great. Thank you, Manish. That was really wonderful. And there'll be a little bit of reiteration of some of the kind of background on how the evidence-based guidelines were developed. In the next 15 to 20 minutes, I'm going to talk specifically about the traumatic pain guideline that was originally developed along with the Seizure Guideline and the helicopter EMS guideline. The only disclosures is similar to what Dr. Shah mentioned, is that we'll be discussing some information generated from grants through cooperative agreements between NHTSA and Children's National Medical Center, as well as through NHTSA and the National Association of State EMS Officials. And then because a fair amount of the groundbreaking work in these areas has been performed by the CHAMP node of PCARN that was originally funded through the EMS for Children Targeted Issues grant program, we will also be discussing some of that research as well. I personally have no financial conflicts of interest. From overall objectives, I want the learner after this small segment to kind of be able to recall some of the barriers to prehospital analgesia administration, and then understand the specific key elements of the evidence-based guideline that was developed, and then also finally identify some potential solutions to barriers of evidence-based guideline implementation in EMS agencies. We have some work that we did with certain states that I'll show here that we used to kind of identify some of those barriers to implementation. So the first question is, how big a deal is pediatric pain? And, you know, it turns out that it's a contributing factor in up to 20% of EMS encounters. And if you think about why people call 911, it's because they're in crisis, and often they're in crisis because they're hurting. And particularly for kids, EMS providers are responding to children who have fractures or burns, children with sickle cell pain crises. Sometimes they may be called for management of headaches and/or even abdominal pain. And in one large multi-center study performed by the Pediatric Emergency Care Applied Research Network, or PCARN, looking at over 500,000 pediatric encounters, about 28% of the encounters were related to trauma. However, only 1% of patients where data was collected on pain management were actually even given any analgesia. So underutilization of analgesia for children in the out-of-hospital setting is frequent and quite problematic. So let's go over a little bit about what the literature historically has shown with management of pain in children. First, Halim Hennis in 2005 did one of the earlier studies looking at this in Milwaukee. He was setting out to kind of examine some barriers to pain management, and he did an interesting survey of EMS providers that involved a query on barriers, which we'll go over, but also the percentage of patients that they thought they were giving analgesia to with certain conditions. And then he compared that to how those patients were actually being treated. And he found that out of a study of 270 patients less than 18, only 3% with fractures were actually given opiate analgesia, and only 9% of burn patients, which was much, much lower than what they had self-reported, the EMS providers self-reported that they were doing. That same year, a study by Dr. Swar examined 73 children with lower extremity fractures and found about 1/5 of them were given opiates, and this is actually a pretty high percentage compared to other studies. Another study by Isaac a couple years later looked at 700 children with traumatic injury. 64% reported pain on pain score documentation, and however, only 2% were actually given pharmacologic analgesia in comparison to 12% receiving non-pharmacologic analgesia. Rogovic out in Australia at the same time studied 310 children with fractures. 3% were given opiates in comparison to 34% actually receiving oral analgesia in the form of Tylenol or paracetamol and non-steroidal anti-inflammatories. Through the CHAMP node, 10 years after Dr. Hennis's original study, Dr. Brown and colleagues looked at over 1,000 children with trauma. And we remember that Dr. Hennis started some very aggressive work on training EMS providers in Milwaukee to document pain scores using a FACES pain scale and to treat children with traumatic pain. However, 10 years later, after all this work, they found that only 25% of children had a pain score documented, and 11% of children overall were given analgesia. This is higher than what Dr. Hennis originally found. They also found that about you were twice as likely to get any analgesia if a pain score was documented, and that is a trend seen in other studies as well. And then Dr. Brown followed up that study examining the entire, or 3 EMS agencies, and in a multi-center study of over 3,000 children, he found that those children with a pain score of 4 or greater, about 15% of them were likely to get analgesia compared to all comers, where analgesia was still only administered to about 5% of children. These are all children with some kind of pre-hospital primary impression of trauma. And the range among the agencies included in the study was between 2% of children and 26% of children. So quite a variance in spread. And I think this is related to culture and other things. And so given this illegal analgesia, we know that there are certain barriers among agencies. What's the side effect of not treating pain in the pre-hospital setting? Well, the clock is ticking. And so when children are injured in the field, the one irony I would say about trauma and pain is that likely the kid is still in pain when EMS arrives. You know, if you're called on scene for a seizure, the seizure may have stopped and may not have needed medication. But if you're called on the scene of a fracture or a bad burn, likely the child still has a bad fracture or a bad burn and needs some pain management. And so giving that treatment immediately will shorten the time that it takes for a child to ultimately be given analgesia. In the McGeechan study, out of 124 children, only 18% received pre-hospital analgesia compared to 91% getting it in the emergency department. And when it was given in the field, those kids got it about 30, the time to administration was about 30 minutes compared to about 2 hours. And SOAR found very similar things in that study he did in 2005. And EMS analgesia was given in 22 minutes compared to 88 minutes when the patient arrived in the ED, and realized that when patients arrive to emergency departments, typically there's a long process. They have to be registered, their name has to go into a system, the medication has to be drawn up, it has to be cross-checked. In our emergency department, it has to be verified by a pharmacist before it can be given, it has to be barcoded and scanned for safety issues, and all those things delay ultimately administering pain management to children. So is there a downside? This is my, oh my goodness, emoji face. I hope everybody likes it. I looked long and hard for this online. The inadequate treatment of pain really does have negative implications in children. And I would say that a lot of these studies are really from procedural pain studies and chronic conditions, but we do know that neonates have long-standing alterations in their response to and perceptions of pain experience after IVs being placed, being intubated, etc. In pediatric oncology patients, those that have painful procedures that are not adequately medicated have increased pain scores in subsequent painful procedures. There's documented post-traumatic stress in previously normal children. And then finally, it actually extends average length of stay. Kids stay longer when you can't get their pain under control. And if they've had illegal analgesia all this time, you find yourself really being behind the goal of getting their pain under control. There are also other continued disparities. So we know that administration of analgesia not only happens at a low level across children as a whole, but it also happens even less in the younger patients. About 6% of infants and toddlers are given analgesia in the pre-hospital setting compared to almost 20% of adolescents. It varies by ethnicity and socioeconomic status. In the same study that Dr. Hughes did, she found that administration of analgesia to children less than 15 years of age was about 6 to 7% of Native Americans, 11% of African Americans, compared to 25% of Caucasians or whites. And then finally, it varies by practitioner. So EMS writers with more experience in focus groups are more willing to provide analgesia to children, probably because they have increased self-efficacy around it. They have increased experience in handling children with bad trauma or significant painful injuries. And so we know that those disparities do occur across all those different factors. Trying to advance my slides here. I think I lost control. Cassidy?
You're moving the mouse, so if you could just double click on the screen. There you go.
There we go. Okay. Now I've advanced too fast. Okay, so the next few slides we're going to talk about prioritizing traumatic pain management in EMS. So the barriers to pain treatment was identified in that original study by Dr. Hennis in 2005, and he found that EMS writers reported a lot of barriers to treating pain, including the inability to assess pain, concerns that kids would have a low pain score, concerns that patients would refuse medication, concerns around vascular access, in other words, whether it would be difficult, whether it was even needed, a fear in delaying transport, a fear of complications en route, challenges in record keeping. I mean, this is a big barrier. And then even a perception of possible drug seeking, and that's probably borne out from their experiences with not, adult patients that they may be coming across. Additional barriers identified through focus groups feel that, as we know, EMS writers often have anxiety with children, just not seeing them frequently in the pre-hospital environment. They do feel that they don't have sufficient training as a result. And then they often will defer to the emergency department, either feeling that EDs would have more expertise in managing pain, or they're actually fearful that they would get in trouble by being more aggressive with pain management in the field. And so as a result, one of the big things that came out in these focus groups was having a positive relationship with online medical control would enable analgesia administration. On the flip side, the question also bears out, do they even need to call for online medical control to be able to treat pain? Shouldn't it be part of standardized protocols? So in terms of access to online and offline protocols, most people on this call who are EMS or children program managers or have worked closely with their state partnership programs, they know that access to online and offline protocols was a goal and a priority and a former performance measure that's now been dropped because 90% of EMS agencies ultimately did report having access to ALS and BLS online and offline guidelines for pediatric care, which is a huge win for the EMS for Children program. When we look specifically at what do these offline protocols actually do for traumatic pain, the Utah EMS for Children program had disseminated an offline guideline for traumatic pain back in 2009. And what they found in some studies subsequently was that there was improved self-efficacy among providers, just being aware that they could have standardized guidelines and protocols that didn't require calling into a hospital for approval to treat with analgesia, improved EMS writer self-efficacy on being able to do that. And then statewide, they looked at analgesia administration through their EMS registry, and they found that their absolute improvement of administration of analgesia to children with traumatic injury from about 18.5% to 26.6%. And in looking closer at the data, they found that provision of analgesia was associated with both documenting that pain score and then also EMS agency training on the protocol. So that brings us to the traumatic pain evidence-based guideline. Obviously, knowing there are disparities and illegal analgesia not adequately treating in the field, and knowing that standardized protocols can improve things, NHTSA worked with EMS for Children to develop the evidence-based guideline for traumatic pain. I do have to give a shout out to my daughter for my little word art because she helped me with that because I did not know how to do that when I was making this presentation, and she promised or made me promise that I would tell everybody that she should help do that. So this is the evidence-based guideline developed by Dr. Gaucher-Hill and Brown and many other co-authors. It addressed the known disparities that exist with challenges in treating pain in the pre-hospital environment, and there are solutions. So the first was that it was going to be consistent across all ages, that pain should be considered in management of all patients, regardless of age. There was fear of dosing mistakes and under-treating, and so they're very easy to remember: pain, dosing, and pain scales based on age. And then finally, the need for medical direction for opiates. This is actually calls for standing orders to avoid having to call medical direction, which has many factors. It could delay transport. It could create some anxiety for EMS providers if they're told no. And so giving people an option for treating pain without having to call for online medical direction was a real move that some of these evidence-based guidelines were going for. And this is the traumatic pain evidence-based guideline. It's very straightforward, and there's basically 4 easy steps. The first one is to use an age-appropriate pain scale to assess pain. For those less than 4 years of age, the recommendation was to use either the FLAC or Faces, Leg, Activity, Cry, and Consolability score, or the CHEOPS score, which is the Children's Hospital of Eastern Ontario pain score. Both these are validated pain scores. They use certain behavioral components such as strength of cry, et cetera, as a way to assess somebody's pain. For the kids that are slightly older, but probably not able to kind of report using a numeric rating scale, those children age 4 to 12, it was recommended to use a FACES-based self-report scale, such as the Wambaker FACES or the FACES Pain Scale Revised. And then for those older than 12, using a self-report scale, such as the numeric rating scale, the classic from a scale of 0 to 10, how bad is your pain? And the reason for this is that you have to be somewhat older and have an ability to abstractly think and process your pain degree into a number, whereas the FACES scale provides a little bit more visual guide to children in being able to report their pain. The next step was to use narcotic analgesia or opiates to relieve moderate to severe pain. One thing you'll note here is that there's no oral option and there's no NSAID option. The evidence-based guideline, as the authors wrote it, was to really reinforce the use of good analgesics, known analgesics, proven analgesics in the field for managing pain. And the dosing there was going to be very straightforward. It was 0.1 milligram per kilogram of IV morphine or 1 microgram per kilogram of IV or IN intranasal fentanyl. These multiple randomized trials of comparing these two medications show that they have equal efficacy in treating pain. Being able to remember 0.1 or 1 against a weight, an estimated weight, seemed like a straightforward calculation, although we know calculations are fraught with problems. But this is really one of the goals, was to kind of create a straightforward way to figure out dosing and give simple guidelines to which medications to use. What about intranasal fentanyl? How is this going to be effective in treating pain? So a couple of studies were done, one out of Indianapolis Fire, where they introduced intranasal fentanyl into their protocols, and they looked at about 950 pediatric trauma patients. They didn't find a significant difference in use of fentanyl. It went from about 30 to 37%, but they did see a significant shift towards intranasal fentanyl overall. And this is in contrast to that study I quoted out of Utah a while ago, when they looked at over 1,100 children with trauma. And they not only found an increase in analgesia administration, but agencies carrying intranasal fentanyl were 5 times more likely to administer analgesia. So there are likely some benefits towards treating pain with intranasal fentanyl, and that's why it was included on the protocol. The next step is to reassess the pain, and I do have to say that this was what people felt like was a strong recommendation and with some moderate quality evidence. And the specific things around reassessing that pain was figuring out if they need additional pain medication or making sure that there's no adverse side effects to the medication. I think that this was developed to, give providers some sense of a way to be able to monitor closely for any adverse effects, and then at the same time know that children needed more treatment. So what is the benefit of this protocol? Maryland actually, after this protocol or guideline was developed, used it to base a statewide protocol on for analgesia administration in the prehospital environment. And the benefit that Maryland has is that they have statewide protocols, so every EMS agency functions under the same protocol as every other agency in the state. And they examined ALS transports of trauma and burns, looking at a total of 2,100 encounters from 2010 to 2012. And what they found was that there was a slight increase in pain treatment from 71% to 84% in children. And the authors of this study, Dr. Brown and others, do note that their rates of pain treatment are much, much higher than have been previously reported. And it may be because they looked at a very select group of patients out of their database. They also found that there was an overall increase in the amount of opiate administered. So not only was there a slight improvement in the number of children getting treated, but specifically, probably children were getting a better dose. that under treatment, even though some analgesia may be given, as you saw from Dr. Shah's data on seizure management, likely the milligram per kilogram dosing was underdosing most of those children. And so by giving guidance on exactly how much to give and specific recommendations on how to redose, they found that there was an overall increase in the amount of opiate administered after implementing this guideline throughout their state. So I'll finish up talking a little bit about evidence-based guideline dissemination implementation. You know, after the guideline was developed and with the Maryland experience, it begged the question, you know, can this evidence-based guideline be disseminated at the state level? What are the best practices to do this? What barriers will be identified? And what patient outcomes can be measured? And this was a cooperative agreement between MITSA and NISEMSO. And what we did was try to examine barriers and enablers to dissemination across these 5 states that you can see there: Wyoming, Idaho, Arizona, Pennsylvania, and Kansas, excuse me, Tracy, Kansas and Tennessee. The project was to develop a way to support these states, and a toolkit for implementation, dissemination, evaluation were developed. Individual implementation plans for each state were developed, including a program plan and evaluation roadmap, and then online training and PowerPoints for EMS personnel, as well as hospital ED staff, so they would know that patients were coming in with treatment, were also developed. These are all available on the NISEMSO website. This is what we found. We had 5 states, 3 of which adopted, and 2 states chose not to adopt, which actually provided a little bit of a natural experiment for us for comparison. All states did submit some data on pre and post pain management and practices, whether they adopted the guideline or not, to give us a sense of what was going on. These are the barriers that were reported. The lack of authority to mandate a new protocol across the state. All 5 states were chosen because they did not have mandated protocols in their state. That would make it so easy. And so we wanted to look what the barriers were. And the lack of authority on the part of the state was a huge barrier. And that meant there was also a lack of statewide infrastructure to support the dissemination implementation process. There were many challenges reported with learning management systems for the training that was put out, as well as making those protocols available. And then finally, every state EMS registry actually had a lack of statewide granular data. And in fact, route of medication administration is not a NEMSIS field that can be tracked. And since all these states were using, we were using the NEMSIS data fields to collect this information, we couldn't really get down to granular detail about what was going on and where. The enablers that we did find were having a state champion really shepherd this project through. They help identify strategies for states to disseminate the guideline when there isn't any kind of mandate or infrastructure. They work closely with stakeholders. They assisted the state in the protocol development, so taking the guideline and translating that into an actual protocol, and then help develop some regional infrastructure. And then the toolkit that was put out was also thought to be a strong enabler for being able to do as much dissemination as they could. And then finally, this was the comparison. So again, you can see in the after column, no data available for Arizona, no data available for Tennessee, because getting that granular data was very challenging. State EMS systems are always in flux. And so there was no measurable improvement in analgesia. However, Wyoming did have a measurable increase in pain score documentation, and Arizona did identify problems with restocking those controlled substances, which, again, that barrier that was reported to Hennis in his original study around paperwork and extra burden was a factor for Arizona, and they were able to troubleshoot that in participating in this program. So what are the next steps? That evidence-based guideline was developed and published in 2014, and certain modalities such as ketamine and nitrous were not addressed. The findings on barriers to dissemination can now help states address some of those gaps in protocols and patient care. And now we also have some prospective studies underway to identify at the EMS provider level at the time of patient care what those barriers to treating pain are, and so that will hopefully inform things in the future. And so I would just invite for you guys to go back to your agencies, your states, your communities, and kind of talk about what tools you have in your toolbox to help improve pain in children. And I think I've gone a little over. I'm so sorry. But I will have you take back control, Cassidy. I'm happy to quickly answer questions or give my time over to Dr. Remick to cover a really important area.
All right, thank you, Dr. Adelgais. Yeah, we have had a few question submissions in the chat box, but we'll go ahead and keep those to the end just for time purposes and turn it over to Dr. Remick. Thank you.
Okay, great. Thank you, Cassidy, and thank you, Dr. Adelgais. That was a fantastic presentation on pain management and extremely important. So I'm going to turn over our focus to cardiac arrest in the pediatric out-of-hospital setting, and specifically focusing on non-traumatic out-of-hospital cardiac arrest and whether or not we should hit the brakes. I have no relevant disclosures to report aside those that were already presented at the beginning, which is that what I present here is my own personal thoughts and opinions relative to the literature and not those of any other government organization or entity. So in terms of the objectives over these next 20 minutes or so is I plan to discuss a little bit about the epidemiology of pediatric out-of-hospital cardiac arrest. We'll talk about some factors that have been shown to be associated with improved survival. We'll also talk about the pros and cons of termination of resuscitation, efforts on scene, and then finally some ways that EMS providers can be supported to engage and encourage families following pediatric out-of-hospital cardiac arrest. So if we could go to the next slide. I just want to highlight that we are not talking about traumatic pediatric out-of-hospital cardiac arrest in this particular presentation. And the reason for that is that there is a lot of literature that surrounds traumatic out-of-hospital cardiac arrest. There are also guidelines relative to this that Mary Fallett and colleagues have written entitled The Withholding of Termination of Resuscitation in Pediatric Out-of-Hospital Traumatic Cardiopulmonary Arrest. We know in this setting that the outcome is fairly dismal. There's about a 4 to 5% chance of survival overall, and essentially all of these patients tend to be neurologically devastated. So rather, what we're going to be talking about today is non-traumatic pediatric out-of-hospital cardiac arrest. So if you'll go to the next slide. I'd like to just kind of start off with proposing this question of what if I said we could save 1,000 more children suffering non-traumatic out-of-hospital cardiac arrest every year in the United States than we do currently. And that may seem like a very aspiring statement, but I actually do believe it's true. And I'm hopeful that over the next 20 minutes I can explain to you why I think that's possible and how we can get there. What I will say is that there is a wonderful economist and policymaker, if you'll just click to the next, by the name of Daniel Kahneman. There you go. He wrote a book called Thinking Fast and Thinking Slow. And he's a renowned psychologist. He also won the Nobel Prize in Economics, and he really defined two systems that drive the way we think. The first is this fast, intuitive, emotional sense, such as if someone throws a ball at you, you quickly move your hand to catch it. And he also described a more deliberate way in which we think logically through a process, and it creates a more rational approach to management. And I would suggest that currently the older, more standard approach to pediatric out-of-hospital cardiac arrest, if you go back really fast, quick, Cassidy, the older approach to pediatric out-of-hospital cardiac arrest has really been driven by that fast thinking, where we tend to follow a scoop-and-run approach. We see a child in cardiac arrest. Oftentimes, first responders and EMS providers will run in, they'll see that patient, scoop them up, run out to the street, try to get them transported as quickly as possible. But I believe if we took a more thoughtful and rational approach that integrates and builds upon our understanding of both the science of cardiac arrest, both in the pediatric literature and adult literature, that we really could save 1,000 more children every year. And so we'll move on and talk about some of the literature that shows us how we can do that. So if you'll go to the next slide, please. So what we do know is that every year in the United States, there's over 5,000 children that suffer pediatric non-traumatic out-of-hospital cardiac arrest. And we know that the survival rate is seemingly low. It's only about 5 to 10%. We know that about 70 to 80% are secondary to respiratory failure. This has been well known for quite some time with the other related to either cardiac issues or shock. And that over the last decade, and I would venture to say even over the last several decades, we really have not seen any improvement in survival from pediatric out-of-hospital cardiac arrest. So if you'll move to the next slide. What we do know in the world of EMS is that we have taken CPR to the next level. We really have turned CPR into a science. We provide the highest quality on scene. We've taken it so far to call ourselves resuscitologists. And I would venture to say that CPR in the field is in many cases better than in-hospital CPR. And part of that is because of our use of things like a pit crew approach that truly adheres to that Nascar idea of everybody has a role, and we quickly jump into our positions, and we provide the highest quality CPR in that way. If you'll go to the next slide, please. We've seen that this has resulted in increased survival over the last decade for adults in particular. We used to see survival rates that were in the 5 to 10% range. Now we're seeing upwards of close to 20% in certain areas and regions. And we know especially that if it's a shockable rhythm, such as ventricular fibrillation or ventricular tachycardias, that we can see survival rates that are in the 30 percentile range, which is just incredible that we can turn that around and actually see maybe a 1 in 3 chance of survival for adults with non-traumatic out-of-hospital cardiac arrest. And what the literature has really teased out is that there are certain things that make a huge difference. We know that early defibrillation, of course, makes one of the biggest differences if it's a shockable rhythm. We know that if we can minimize interruptions, that's critical, because every time there's an interruption, especially interruptions that last for more than 10 seconds, that blood pressure that we've obtained begins to drop and we have to start all over. We know that full chest recoil is critical in terms of refilling of the heart and ensuring that we actually have enough to be able to blood to actually push out to perfuse the body. We know that there is an optimal rate for chest compressions and an optimal depth for chest compressions, and if we can achieve that over 80% of the time, then there's a much higher chance of survival. We know that these choreographed approaches have proven very beneficial in the adult literature. We also know that there's a trend towards CPR on scene as opposed to en route. And we know this because when we perform CPR en route in the back of an ambulance, that CPR by definition is of variable quality, meaning that there's more likelihood for interruptions and changes in rate and depth. And not to mention that this is truly dangerous for providers who are standing up in the back of a moving ambulance and trying to be more effective in what they're doing. And they're not putting themselves first, of course. We know that there's a lot of questions about airway management. There's still not quite consensus around this. Is BVM better? Is advanced airway better? What about supraglottic airways? There's lots of studies out there. There's still questions, and hopefully this will be answered in the coming years. We also know there's questions around mechanical CPR. For quite some time, there was this push towards using mechanical CPR devices, especially in low-resourced areas, especially during transport. But we also have seen recently in some of the literature that mechanical CPR may not be quite as perfect as we thought it once was. However, it may certainly still have a place in resuscitation. And then lastly, of course, there are national guidelines for termination of resuscitation when it comes to the adult out-of-hospital cardiac arrest population. If you'll move to the next slide, please. But what we do know is that kids, of course, are not quite like adults, at least not in some ways. We know that airway management tends to be a priority, especially knowing that 70 to 80% of cardiac arrest in children is due to a respiratory cause. We also know that there are issues around drug dosing safety and medication administration, in which errors are very common due to weight-based dosing. There's still tendencies to sometimes use math on scene, which creates all sorts of challenges. And we also know that when we're working with children, it's not just the child we're working with, it's actually the family. And that especially when it comes to cardiac arrest, the family needs to know that we know what we're doing and we need to be able to communicate with them effectively to ensure the best possible outcome. But there are some key principles that are absolutely the same when it comes to children just as it does in adults. We need to be able to rapidly assess these patients. We need to be able to monitor these patients closely. We need to provide effective interventions. We need to be looking at how we're performing in order to improve over time, and that requires quality improvement processes and plans. And lastly, we know that we need to rely on the evidence base that exists and not on that fast thinking or that emotional, quickly moving out to the street where we can transport that child to the hospital. If you'll click down, what we do know is that, as I mentioned, there's really been no increase in survival from non-traumatic pediatric out-of-hospital cardiac arrest in the last decade. And I know that we can make some improvements there if we review the literature. So if you'll move to the next slide. All of this kind of brings up some questions about kids and maybe why aren't they more resilient? Why are their survival rates so much lower? And some of the questions you might be asking is, well, are kids just less likely to survive? Is there some kind of inherent factor? Is there something about the physiology? We all talk about falling off the cliff and not being able to get these children back. And then maybe the last question is it just that the science of pediatric resuscitation is really lagging behind that of adult medicine, and that there really is more that we can do to support this population? So if you'll move to the next slide. I'd like to turn my focus just for a few minutes to what we can glean from the pediatric in-hospital cardiac arrest literature. Similar to out-of-hospital cardiac arrest, for quite some time, we knew that survival rates were quite poor. And in the 80s and 90s, we saw 5 to 10% survival rate, just like what we're seeing in the out-of-hospital setting. But over the last decade and a half, we've seen significant improvements in survival rates. And in fact, in these two different studies by Nadkarni in 2005, where they did a prospective study of over 880 children, and all of these children had pulseless cardiac arrest that required compressions and defibrillation and both. And what they found that, in fact, children had higher survival rates than adults. There was a 27% survival rate for children versus only an 18% survival rate for adults in that study. And then more recently, in the study by Girotra, where they looked at over 1,000 children from 12 hospitals across the U.S. who had in-hospital cardiac arrest. That was initially an asystole or a PEA rhythm. And what they found was this significant increase in survival where they'd moved over the last 10 years from a 14% survival rate to up to 43% survival rate for in-hospital cardiac arrest. And this speaks to the fact that just because a child is in cardiac arrest doesn't mean that we don't have an opportunity to get them back. And these studies show that maybe our survival rates could be as high as 1 in 2 as opposed to 1 in 10. And the reason they've seen these improvements in survival in the in-hospital setting is due to the implementation of rapid response teams and early interventions, of course, and most importantly, due to the initiation and adoption of high-quality CPR that really speaks to the evidence base of what we know about resuscitation. If you'll move to the next slide, there was another nice study that looked at the quality of CPR that was being delivered in an in-hospital setting. This was a study done by Sutton and colleagues where they looked at the delivery of chest compressions, and looking at over 36,000 chest compressions that were actually being delivered. They saw that the compliance with AHA depth and rates were not as good as they hoped, even in the in-hospital setting and even in an intensive care unit setting. And so there's oftentimes room for improvement even when it comes to in-hospital cardiac arrest management. If you'll move to the next slide. So what we do know as well is that from some recent studies that have been done in the in-hospital literature is that when we do provide early administration of epinephrine, typically within less than 5 minutes, if not even less than 1 minute, that is associated with an increased chance of survival, 33% versus only 21%. There's also been some recent studies that have looked at over 1,000 patients with in-hospital cardiac arrest where they compared longer intervals of epinephrine dosing compared to the less than 5-minute intervals. And what they showed is that in those patients that receive epinephrine dosing at the 5 to 8 minute or even 8 to 10 minute intervals, that the odds ratio for survival approached 1.8 to 2.6 in those two different categories. And lastly, in the in-hospital setting, looking at about 2,200 in-hospital cardiac arrests, where the median age was about 7 months, and the majority of these patients were secondary to respiratory causes, that there was a decreased chance of survival when they were intubated early during that cardiac arrest of 36% versus 41%. So if we'll move to the next slide. So the question you might be asking is, how can we identify those children who might be likely to suffer from or to benefit from prolonged resuscitation? There were a few studies that have also been done looking at exactly this and the duration of CPR and survival. And if you'll move to the next slide, Cassidy. You'll see in this study by Matos and colleagues where they looked at the mean duration of CPR for survivors versus non-survivors in the in-hospital setting. And what they found that indeed survivors were more likely to have lower durations of CPR, approaching 10 minutes versus 25 minutes, and adjusted probability ratios that you can see there. The longer the duration of CPR, the less likely survival was to occur as you move past the 15-minute mark especially. And not surprisingly, when you look at the breakdown of the different categories, those who suffered from trauma, we see lower rates of survival overall, even from the get-go, and from those who had cardiac-specific causes where they were more likely to have shockable rhythms, were much more likely to survive than the other groups of patients studied. If you'll move to the next slide. What they also found was that if we follow that duration of CPR and look at survival to hospital discharge and favorable neurologic outcomes, that we see about 27% survival and 19% favorable neurologic outcomes in those patients that have shorter durations of CPR approaching 10 minutes. But this helps us to identify at what point should we actually stop CPR and maybe think about this child as not being able to benefit from our resuscitative efforts. And so studies like this help us as we begin to develop evidence-based guidelines. If you'll move to the next slide. What we know currently for pediatric out-of-hospital cardiac arrest is that the 1-month survival with a high cerebral performance score of 1 to 2 is extremely low if we do not achieve return of spontaneous circulation prior to transport. And in fact, it's less than 1%. We know that there are certain areas that increase our chance of survival, certain characteristics. Certainly if a child receives bystander CPR and thus it's a witness arrest, or if there's a shockable rhythm, or if at least they have some kind of electrical activity, even if it's still not a shockable rhythm. If you'll move to the next slide. We also know that there are a number of other items that we can glean from the current literature related to pediatric out-of-hospital cardiac arrest. Hansen and colleagues looked at airway management, and what we do know is that advanced airway management procedures are relatively infrequent compared to adults. We really only see about airway management in children in about 4% of all cases, and for advanced airway management, less than 2%. And in those, of course, not surprisingly, the success rates are lower compared to adults. Hansen also looked at the benefit of BVM over endotracheal intubation or supraglottic airways and seemed to see a slight degree of benefit to using basic airway maneuvers over advanced airway maneuvers. More recently, in a study by Titson where they looked at over 2,000 patients in cardiac arrest, that longer scene times were associated with increased survival, and this suggests that maybe if we're actually doing something on scene to help resuscitate these patients, that we're much more likely to see increased rates of survival. And in this study, they saw a doubling of survival rates. And then even more recently, by Banerjee and colleagues, they've seen that by actually providing early on-scene management where they prioritize airway management and high-quality CPR, in place of early transport, that they saw increases in survival that went from a 0% survival rate up to 23%. And that's enormous. And then more recently as well, in a study done out of Travis County, pit crew approach, just similar to what we're doing in adults, where every person has a role. And we prioritize, depth and rate and choreographed CPR, that too was associated with a higher rate of survival where the change was from 0 to 17%. If you move to the next slide, we know there are a number of factors that increase chances of survival. As I've mentioned, bystander CPR, early compressions with effective ventilations, and of course, high-quality CPR. And if you'll go to the next slide where we can actually look at this table more closely, you'll see that in this study, they saw that bystander CPR made a significant difference for neurologically favorable outcomes at 1 month survival, where the odds ratio was 4.17, and then that conventional CPR in children actually performs better than compression-only CPR, likely because of the high rates of respiratory failure prior to the onset of cardiac arrest, where we're seeing odds ratios that approach 6. If you'll move to the next slide. There's also been studies similar to those that have been done in the in-hospital setting looking at the duration of CPR and favorable neurologic outcomes. And this was a study done out of Japan where they looked at over 12,000 pediatric patients and 30-day survival with high CPC scores. And for the duration of pre-hospital EMS-initiated CPR, they noticed that the chance of a favorable outcome diminished to less than 1% at about the 42-minute mark. And that was for both 30-day survival and 30-day survival with a high cerebral performance index. There was some slight variation that they found based on the initial rhythms. Of course, for shockable rhythms, it decreased to less than 1% at about 39 minutes, and then for PEAs, less than 1% at about 46 minutes. But this is important to note because it helps us to better understand how long should we continue CPR on scene if we have a pediatric cardiac arrest patient. If you'll move to the next slide. What we do know when it comes to pediatric cardiac arrest and the paramedic perspective is that we don't see pediatric arrest nearly as often. We also know that only about 7% of paramedic providers reported that they experienced pediatric termination of resuscitation. And that means that they feel relatively unprepared to be able to terminate resuscitative efforts on scene. They're worried about how the family is going to respond, and for this reason, there's a sense that it's better to transport that patient to the hospital. But most of these providers believed that pediatric patients had at least the same, if not a better chance of survival than adults, which we know from the literature is just flat out not true. And of course, they felt uncomfortable with pediatric termination of resuscitation, even after they were told that children had a worse prognosis. We can't really move forward with pediatric termination of resuscitation or even early onset on-scene resuscitation in children unless we have the opportunity to provide or think about termination of resuscitation on scene. And in some work that Mary Fallett out of Louisville, Kentucky has been doing as part of a children's grant is to look at how many states and or EMS agencies have pediatric TOR protocols. And you'll see that those numbers are low, with only about 30% of states and EMS agencies reporting that they even include children in their termination or resuscitation protocols. So if you'll move to the next slide. So what are some of the pros and cons of termination or resuscitation? Well, we know if we get out to long resuscitation efforts that survival can be dismal in this population. We don't want to give false hope. We know that there can be significant financial burdens for those patients that we do transport, and there can be significant resource and cost savings for both the family and the EMS system if we don't transport patients that we know are not going to survive. But we do know that when it comes to terminating children on scene, that family members can often be devastated, that providers don't have the training in general to be able to do this, and they need support. And there are certainly other concerns about limited personnel to provide that support, legal liability, although there have been very, very few reports of any kind of issues related to that. But organ procurement can be significant and very helpful. And the next slide, I just wanted to share with you all this wonderful work that's being done by Mary Fallett and colleagues as well for a program called COPE, which stands for Compassionate Options for Pediatric EMS. This is a program to help equip EMS providers with the skills and knowledge to help families in the circumstances surrounding pediatric out-of-hospital cardiac arrest. And in addition, it helps provide EMS providers with information on how to prevent or recognize depression and prevent secondary trauma from occurring in this really important population. I want to finish up with just a couple of slides, if you'll move to the next one, which is just that we know there are significant gaps in pediatric out-of-hospital cardiac arrest management when it comes to children, especially compared to adults. And this is a graphic demonstrating in-hospital versus out-of-hospital cardiac arrest rates over the last 15 years and the differences in survival. And we see that when it comes to pediatrics, we've seen massive improvements in in-hospital cardiac arrest, but with respect to out-of-hospital cardiac arrest, almost none. The recent studies that have come out by Banerjee and other colleagues out of Polk County, Travis County, and there are some areas where we're really starting to see best practices surrounding on-scene early resuscitative efforts, and that if we're going to get children back, we're most likely to get them back in those first few minutes of resuscitation, not 10 minutes after a variable transport and variable CPR en route. So it's really important that we begin to think about how we can improve our rates of survival. And so if you'll just move to the last slide, I just want to provide a summary of what I would hope would be our new vision for management is that we really support and promote dispatcher-assisted and bystander CPR for children, and that includes promoting CPR training for the public, that we provide high-quality CPR on scene immediately to children that are suffering cardiac arrest, especially in the non-traumatic setting, that we think about these choreographed approaches such as pit crew to pediatric resuscitation, that we move away from that scoop and run approach where we know the quality of CPR that's being delivered and the early resuscitation efforts are poor. We think about including children in our termination of resuscitation protocols. And finally, we really foster family-centered care and EMS provider training to help communicate with families around the death of a child. And with that, I think I am essentially finished. There's one last slide. And hopefully we can move to 1,000 more children a year that survive from pediatric out-of-hospital cardiac arrest. I'm sorry to go over. Thanks, Cassidy.
Thank you so much for your time, Dr. Remick. No worries about that. This was all very valuable information, so it was definitely worth the time. If everybody has a little bit of time, there was 2 questions that were submitted through the chat box. One for sure is for Dr. Remick, and that question comes from Carolina Robert Santana. And the question is, what is the recommendation for time on scene for non-traumatic OHCA?
So there is no official gold standard or recommendation around that. There have been some studies that have looked at the 30-minute point, but as I just showed you in some of the studies that have come out regarding duration of CPR, it's probably around that 40 to 45-minute mark where we see a less than 1% chance of survival across all categories of pediatric out-of-hospital cardiac arrest. That, however, still needs to be teased out. Some of this, these pediatric termination and resuscitation on scene would best benefit at this point from online med control and having physicians involved in that work since there are no official national guidelines that have come out yet, but still more to come. I hope that answers your question, Carolina.
Great, thank you. I will wait for her response. The other question comes from Patrick, and she just responded, yes, it does, thank you. And the other question from Patrick is, how do you encourage on-scene treatment as opposed to scoop and run? Most providers seem nervous or scared to administer interventions aggressively due to med math, etc.
Sure. Well, med math is certainly a problem, which is why we need to have, systems in place that help support administration of drugs overall, and that comes not just with cardiac arrest, but certainly with pain management, as Dr. Adelgais was discussing, and even with steroid management and the like, as Dr. Shah was discussing. But in terms of encouraging early resuscitation efforts, I think it's really understanding the science and evidence that exists behind pediatric cardiac arrest, which is that we know about 80% go into cardiac arrest secondary to respiratory causes. And if we don't quickly restore circulation and oxygenation, ventilation in these children, then we're unlikely to get them back. And we're most likely to get them back in those first few minutes. So if we don't at least start resuscitative efforts early, provide that high-quality CPR, then we're missing a significant opportunity. what we're doing by scoop and run and just moving into the ambulance is really solidifying the outcome for those patients, especially given the studies that we know those children who we do not achieve ROSCN or return of spontaneous circulation, that the chance of survival once they get to the hospital is absolutely less than 1%. So if we can at least start with the evidence base and look at that, start resuscitative efforts early, then we might be able to change that outcome.
Yes, and Patricia just actually agreed with you. She says she's currently on a basic life support ambulance, so no. All right. Thank you, Dr. Remick, and to the rest of our speakers, Dr. Adelgais and Dr. Shah. This was fantastic information, and thank you all for staying with us. It was definitely a valuable little over an hour of our time for today. That being said, if anybody is looking for CAPC credit, that link is in the chat box. So do make sure that you click on that and sign in. And also the full recorded webinar, along with the PDF of the slides, will be available on our website within 24 hours. That link to the website is also available, so definitely check it out. There's a lot of great information, especially for EMS Week resources for this week as well. So that being said, thank you again to the three of our speakers. Completely appreciate all of your time today. And everyone have a fantastic rest of your Wednesday. Happy EMS Week to everybody.
Thank you.
Thank you.
And I thought, good, okay, cool. Why do you want to try them on? Oh, heck no. No, I'm good. Well, I'm sure that fits you. The big.
All right, let's just go.
I don't know.
Forget
Okay,
about
we're
that.
going. I don't need to make. I know, but I
put your foot up. Put your foot up.
I got to church and pay bills.
Well, then pop it up there, okay?
If I can take the chair from Kippa.
Well, do it. I think that's more important.
Well, I just need to go take a water pill, but I haven't done that.
Well, that's more than a water pill, Sandy.
She says no.
Who does? The one down here?
Yes.
Well, I'd rather be safe than sorry, right?
I guess. See, I propped the chair so I could